Usually when we talk about receiving a medical diagnosis, there's this inherent expectation of precision.
Right. Yeah. Like it's math.
Exactly. It feels like engineering.
Yeah.
Like if you break your arm, you go to the hospital, the X-ray shows that jagged white line on the screen,
Yeah.
and the doctor just points to it and says, there's the problem.
It's visual, it's binary, and honestly, it's incredibly comforting. I mean, as patients, we like our ailments to be visible. We want a clear enemy to fight.
Yeah, you cast it, the bone knits, and you just move on. But then you step into the world of psychiatry.
Oh, yeah. That's a whole different ballgame.
Right, into the realms of like neurodevelopment, trauma, severe anxiety, and clinical depression.
Yeah.
And suddenly that metaphorical X-ray machine is just completely useless.
Yeah, it really is. We're looking at a diagnostic and treatment landscape that is profoundly murky.
We're trying to measure invisible pain.
It's the absolute definition of diagnostic muddy waters. And frankly, the traditional tools we've been using to navigate those waters for, well, last several decades, they're really starting to show their limitations.
And that is exactly why we are plunging into this deep dive today. So whether you are prepping for a board meeting on mental health innovations, or you're just wildly curious about the inner workings of the human brain, today's topic represents a massive paradigm shift.
A total shift, yeah.
We're looking at a comprehensive 2020 review article. It's titled Psilocybin-occasioned Mystical Type Experiences. And this is put together by researchers from Cardiff University and Imperial College London.
Really incredible teams over there.
Yeah, top tier. And our mission today is very specific. We are going to explain exactly how psilocybin-assisted therapy actually works for patients dealing with severe anxiety and depression. We aren't just talking about the cultural hype here. We're talking about the biological mechanics. Okay, let's unpack this.
Let's do it.
To understand why scientists are looking at psychedelic mushrooms, we first have to understand the wall that modern biological psychiatry has hit, right?
Yeah, exactly. Because, think about the last 100 years of modern psychiatry. We have made incredible life-saving strides.
For sure.
The introduction of SSRIs and other antidepressants fundamentally changed how we manage mental illness. But we still hit this massive wall when it comes to consistently effective treatments, especially for treatment-resistant patients.
The ones who just don't respond to the standard drugs.
Right. What we see frequently in the clinic is a phenomenon called polypharmacy.
Which is when a patient is prescribed multiple medications at the same time to treat the same illness,
Right.
or to treat the side effects of the original medication.
Yes, exactly. That cascade of prescriptions is incredibly common. A patient is given one drug for severe depression, but, it causes insomnia.
So they get a sleeping pill.
Right. They get a second drug to help them sleep. But then that second drug causes daytime anxiety, so a third medication is added to the mix.
Wow. Just a compounding cycle.
Yeah, and the data clearly shows this approach often lacks long-term efficacy. Worse, it actually increases the risk of harm because these drugs are interacting in highly complex, sometimes totally unpredictable ways within the brain's chemistry.
And when you combine that sort of pharmacological trial and error with a severe lack of accessible non-drug psychotherapy in a lot of global health systems,
you have a field that is urgently needing a breakthrough.
right.
Psilocybin is not being presented in this research as some fringe counterculture rebellion. It's being explored as an urgent, viable, and highly rationalized intervention in a medical system that is desperately looking for better tools.
Okay, so to really understand how a compound derived from a fungus is being used to treat clinical depression, we kind of have to throw out our preconceived notions of what a psychiatric treatment room looks like.
Oh, absolutely.
Because if you picture a sterile doctor's office with, like, fluorescent lights, a ticking clock, and that crinkly paper table, you're entirely missing the mechanism of action.
Yeah, you really are. The environment, what the researchers rigorously define as the setting, is meticulously crafted, and it's integral to the therapy itself.
It's not just take 2 of these and call me in the morning.
Not at all. A patient doesn't just swallow a pill and go home. They come in for a session that lasts an exhausting 7 to 8 hours.
7 to 8 hours, wow.
Yeah. And the room is designed to feel somewhat like a comfortable living room. The patient is usually lying down on a couch. They're given an eye mask to wear, and they listen to a carefully curated, high-fidelity playlist of instrumental music.
An eye mask and music. So you're actively, like, cutting off their visual connection to the room and driving the entire experience inward.
That is the specific intent, yeah. They are explicitly instructed to focus their attention inward to confront whatever internal terrain arises.
And they aren't alone in there, right?
Crucially, no, they are never alone. They are accompanied by two monitors or guides throughout the entire duration of the drug's effect.
Who are these guides?
Traditionally, the clinical studies have used a male-female dyad for these monitors, though other pairings are used based on patient comfort. But these monitors are not there to psychoanalyze the patient.
They aren't doing talk therapy while the person is hallucinating.
No, no traditional cognitive behavioral therapy while the drug is active. They're there to provide supportive, empathetic, clinical sensitivity. They're basically just holding space.
And they're holding space for a very specific, almost paradoxical goal. I mean, they aren't just hoping the patient feels a little less sad by the end of the day. They're actively trying to facilitate what the literature clinically terms a complete mystical type experience.
Which is such a wild term to read in a medical journal.
Right. The phrase mystical type experience sounds almost wildly out of place in a peer-reviewed modern scientific paper. It sounds like theology, not biology.
It does, but the researchers really acknowledge the deep historical and anthropological roots here. The source actually quotes the famous Mazatec indigenous healer Maria Sabina.
Oh, I saw that. What was the quote?
She said, "Siempre se tomaron para que los enfermos sanaran," which translates to, "They were always taken to cure the sick."
That's powerful.
It is. Modern science is essentially trying to clinically harness, quantify, and standardize an experience that indigenous cultures have utilized for centuries for communal and individual healing.
Okay, but I have to push back here, though. This is the part that always trips me up. How on earth does modern rigorous science measure something as slippery and entirely subjective as a mystical experience?
It's a great question.
Because if I go to the doctor for an infection, they draw my blood, right? They measure my white blood cell count. You can't draw a vial of blood and say, yep, their mystical levels are elevated today.
No, you can't. And that is the exact challenge researchers faced when bringing this into a clinical trial setting. But they solved it by relying on heavily validated psychometric tools.
Like questionnaires.
Exactly. They use instruments like the States of Consciousness questionnaire or the SOCQ. To qualify in the clinical data as having had a complete mystical type experience, a patient needs to score at least 60% on every single subscale of that very detailed questionnaire.
Okay, so they're measuring specific phenomenological markers. What are the patients actually experiencing in that room that checks those boxes?
The reports are profoundly consistent across completely different demographics. Patients report an overwhelming feeling of unity and interconnectedness with all people, nature, and things.
Like losing the boundary between themselves and the world.
Exactly. They report a deep sense of sacredness, profound joy, peace, and a sensation of transcending normal time and space, like existing completely outside the flow of hours and minutes.
Wow.
They also report ineffability, meaning they feel the experience is literally impossible to accurately describe using human language. And crucially, they report an intuitive, unshakable belief that the experience is a source of objective truth about the nature of reality.
So when a patient hits those markers, when they undergo that complete psychological event, the research points to a result they call a quantum change, which is a fascinating term.
It really is. In behavioral psychology, a quantum change is the exact antithesis of a slow, gradual improvement over years of weekly therapy.
It's fast.
Very. It's defined as a sudden, dramatic, and enduring transformation in a person's emotion, cognition, and behavior. It is a massive overnight pivot in how they perceive their own identity and their relationship to the world around them.
I mean, feeling a deep sense of unity with the universe sounds beautiful, truly. It sounds like a lovely afternoon. But I am struggling with the causality here. I need to know the biological mechanics.
Right. The how.
Yeah. How does ingesting a specific chemical actually force the brain into a state where a quantum change is even possible?
It really comes down to evolutionary chemistry and how closely psilocybin mimics our own endogenous biology. So when you ingest psilocybin, your digestive system metabolizes it into its pharmacologically active form, which is called psilocin. Now, if you look at the chemical structure of a molecule of psilocin right next to a molecule of the neurotransmitter serotonin, they are practically identical twins.
I saw those diagrams in the paper. To the untrained eye, they look like the exact same drawing.
They do. The differences are incredibly minor. Think of them like two keys cut for the exact same lock.
What?
The psilocin key has teeth that are just a fraction of a millimeter different from the serotonin key.
Oh.
Because of this near-identical structure, psilocin acts as a functional agonist. It slips perfectly into the brain's 5-HT2A serotonin receptors and activates them. But because its teeth are just slightly different, it unlocks a completely different neurological cascade than regular serotonin does.
Okay, let me see if I can translate that neurological cascade into an analogy.
Go for it.
We hear a lot about the default mode network, the DMN. Let's imagine the brain is a ski resort, and the DMN represents the deep, established grooves in the snow that have been carved out by years of people skiing down the exact same path.
I like this.
Right, so for someone with severe depression or anxiety, those grooves are incredibly deep ruts of repetitive, negative self-talk. If you try to ski down the hill, you inevitably get caught in those deep tracks. Is psilocybin essentially a fresh, heavy snowfall that temporarily fills in all those deep ruts, allowing the skier to glide down entirely new, unexplored paths on the mountain?
That is a phenomenal way to conceptualize the concept of downregulation. It really is. The research shows that psychedelics drastically decrease connectivity within the default mode network.
And the DMN is what gives us our sense of self, right?
Yes, the DMN is the brain's internal monologue center. It is highly active when we ruminate on the past, when we project anxiety into the future, or when we obsess over our self-image.
So the heavy snowfall shuts that down.
Exactly. When psilocybin disrupts that network, when it drops that fresh layer of snow, patients often experience what is called ego dissolution, the rigid, overzealous internal filing clerk that constantly reminds you of your anxieties simply goes offline.
But if the ego is offline and those deep, anxious tracks are covered up, what is the rest of the brain doing?
Well, while the internal monologue is quieted, communication between completely distinct, separate brain networks actually explodes. It creates whole brain integration. The source material explains that the drug desynchronizes the oscillatory rhythms in the cortex.
Which means what exactly for the listener?
Okay, imagine the brain's prefrontal cortex as a very strict orchestra conductor, making sure every section plays to a very rigid, predictable beat.
Okay.
Psilocybin basically makes the conductor drop the baton. Suddenly, the string section is improvising directly with the percussion. The brass is talking to the woodwinds in ways they never usually do.
So it's chaos, but like constructive chaos.
Yes. By disrupting the prefrontal cortex's usual dominance, older, ancient brain systems are allowed to take a central role in subjective awareness. For instance, the mirror neuron system, which is deeply tied to empathy and our ability to intuitively understand others, suddenly gets a much louder voice in the room.
And the researchers tie this entirely novel neurological state to a very specific, deeply human psychological construct, the concept of awe.
Yes. What's fascinating here is that awe is the emotional centerpiece of this intervention. The feeling of awe leads directly to the psychological sensation of the small self.
The small self, like feeling physically tiny.
Exactly. Think about standing on the edge of the Grand Canyon or looking up at a perfectly clear night sky. When you are struck by profound awe, you feel physically and psychologically small in comparison to the vastness of the cosmos.
And suddenly your email inbox doesn't seem so important.
Exactly. Your personal problems suddenly feel less all-consuming. And the data suggests that people who naturally score high in the personality trait of openness are particularly primed for this.
How so?
Well, if you're the kind of person who gets physical chills listening to a beautiful piece of music, you have a high baseline capacity to absorb yourself in external stimuli. That makes you highly receptive to this mystical type experience of awe.
Okay, I understand how the brain is communicating in entirely new ways. The ego is offline, the snow is fresh, and the patient is experiencing profound awe. But here's the piece I am still wrestling with.
Okay.
How does a temporary feeling of awe, which is essentially brought on by a chemical hallucination, translate into an actual, lasting clinical cure for severe depression? If the drug wears off after 8 hours, why doesn't the depression just come right back the next day?
And this is the million-dollar question.
Yeah.
This is where the source material completely upends how we traditionally view pharmacology. It's a massive conceptual leap.
Okay.
The psychotherapeutic benefits, like the actual long-term reduction in depression scores, are not dependent on the dose of the drug.
Here's where it gets really interesting. Wait, it has nothing to do with the amount of the chemical in their bloodstream?
Not directly, no. The enduring healing is almost entirely dependent on the quality of the mystical experience.
So a higher dose doesn't mean a better cure.
Right. You could give a patient a high dose, but if they resist the drug or if the environment is wrong and they don't achieve that psychological breakthrough into awe, the long-term therapeutic benefits simply aren't there.
Wow.
This happens because psychedelics function as what the researchers term meaning response enhancers.
The meaning response. When I read that in the source, it honestly sounded like a fancy term for the placebo effect. Is it just the placebo effect on steroids?
It incorporates the placebo effect, but it is vastly more comprehensive than that. The meaning response encompasses all the extra pharmacological elements of healing. It includes the ritual of the treatment, the symbols of medicine in the room, the deep trust of the patient places in those two guides holding space.
So it's everything around the drug, too.
Yes, psychedelics essentially put a massive magnifying glass over the patient's set and setting. Set being their internal psychological mindset, their readiness to confront trauma, and setting being the physical and interpersonal environment.
Are you saying that if a patient enters that room with a profound expectation that they are going to heal, the psilocybin amplifies that expectation to such an intense degree that the expectation itself becomes the biological mechanism of healing?
That is precisely the working theory. The human brain does not easily differentiate between a profoundly meaningful internal experience and a profound external reality. If the subjective experience feels sacred and deeply meaningful, the brain treats it as vital information.
It rewrites the code.
Literally. The researchers propose that this intense meaningfulness might actually modify the epigenome. We're talking about intent-oriented gene expression. The sheer overwhelming power of the meaning response might literally change how genes related to neuroplasticity are expressed in the brain.
So the brain says, this experience was incredibly significant. I need to rewire my neural pathways to adapt to this new understanding.
Exactly. It's amazing.
That is mind-bending. A psychological realization forcing a biological epigenetic change. And on a day-to-day cognitive level, the researchers note that this meaning response creates a state of psychological flexibility.
Right, because when someone is trapped in severe depression or end-of-life anxiety, their cognition is incredibly rigid. They view themselves, their past traumas, and their illness through a completely fixed, negative, and inescapable lens.
And the drug shatters that lens.
Yes, the mystical experience, characterized by that feeling of the small self, fundamentally shatters that rigidity. It introduces psychological flexibility. It allows the patient to actively reframe the narrative of their life.
They can see themselves from the outside.
Exactly. They aren't just having a strange, trippy afternoon. They are acquiring a new cognitive toolkit. They can suddenly look at their trauma and realize, this happened to me, but it is not the entirety of who I am.
It sounds miraculous, but we have to look at the reality of playing with the brain's foundational architecture, flooding the meaning response, shutting down the default mode network, amplifying a person's deepest internal mindset that has to carry significant risks. You cannot just drop that kind of bomb into every single brain.
Oh, absolutely not.
Yeah.
This therapy is definitively not for everyone. And the clinical trials enforce incredibly strict exclusion criteria to manage the physiological and psychological risks.
Who gets excluded?
Patients with any psychotic spectrum disorders, schizophrenia, or bipolar disorder are strictly excluded from these trials. The same goes for patients suffering from severe depression that is accompanied by psychotic features, or even individuals who have a direct family history of psychotic disorders.
Because the nature of the drug could act as a catalyst for those underlying conditions.
Exactly. Psilocybin heavily alters perception, and it can induce temporary paranoia, intense fear, and transient delusions. For a neurotypical brain, this is a temporary state. But for someone on the psychotic spectrum, there is a very real, documented risk of exacerbating psychosis or triggering a latent condition.
What about people on standard antidepressants?
Right. Furthermore, patients who are currently taking common daily psychiatric medications like SSRIs, MAOIs, or lithium are also excluded.
Is that due to dangerous chemical interactions, like serotonin syndrome?
It is partly about safety, but predominantly it's because those daily medications actively blunt the psychopharmacological effects of the psilocybin.
They block it.
Essentially, yeah.
Yeah.
If you are taking an SSRI every day, your 5-HT2A receptor site are already heavily occupied or they've been downregulated. The psilocin simply cannot find the locks to put its keys into.
So it just wouldn't work.
The patient wouldn't experience the therapeutic effect. Therefore, a patient would have to undergo a carefully medically supervised period of tapering off their daily medications before trying this therapy, which requires a rigorous risk-to-reward assessment by their clinical team.
Okay, that makes pharmacological sense. But let's talk about the elephant in the room when it comes to psychedelics.
Yeah.
What about the terrifying experiences?
Ah, the bad trip.
Yeah. If the drug takes whatever mindset you have and turns the volume up to 1,000, and a depressed patient goes into that room feeling deeply sad or anxious, Couldn't a terrifying, panic-inducing hallucination make their trauma infinitely worse?
It's the most logical concern to have, but the clinical research presents a finding here that is deeply, wildly counterintuitive. They have extensively studied these challenging experiences, sessions that are dominated by acute fear, panic, profound grief, and sadness.
Mm.
And what the data reveals is that the difficulty of the psychedelic experience is actually positively related to enduring life satisfaction afterward.
Wait, let me make sure I'm hearing that correctly.
Yeah.
The harder and more terrifying the experience is in the room, the better the psychological outcome is months later.
In a majority of cases, yes. A significant percentage of individuals who endured highly challenging, even frightening experiences attributed immense, increased life satisfaction to having gone through it.
That is wild.
It appears that confronting that intense psychic pain, like looking the monster of your trauma directly in the eye instead of suppressing it, is a necessary fundamental component of achieving that quantum change.
But how does a therapist handle that in the moment? If I'm sitting with a patient who is experiencing cosmic terror for 3 hours, my immediate human instinct would be to give them a sedative, like to pull the ripcord and stop the suffering.
Right, and that instinct is exactly what the clinical guides are trained specifically not to act on. Because of this paradox where the challenge equals the healing, clinical strategy dictates that guides should never try to reduce the peak difficulty of a challenging experience.
They just let them panic.
They don't try to distract the patient or numb the fear. Instead, their intervention is focused purely on reducing the duration of the panic by helping the patient lean into it. They provide a calm, grounded presence.
Like holding their hand.
Exactly. They might hold the patient's hand and encourage them to surrender to the feeling, to breathe through the terror, and to literally ask the fear what it has to teach them. Moving through the psychological fire, rather than escaping it, is the mechanism that builds the psychological flexibility we talked about earlier.
So what does this all mean for you, the listener, trying to navigate a world where a mental health crisis seems to be living over every headline? It means that psilocybin-assisted therapy is not a magic pill.
Definitely not.
It is not about popping a tablet to numb a symptom the way you might take a painkiller to silence a bad headache. It's a profoundly demanding, exhausting, 8-hour psychological intervention.
It's hard work.
Very hard. And it works because it physically rewires the way brain networks communicate. It uses the overpowering psychological force of awe to shrink the ego. And it relies entirely on the patient's own innate capacity for meaning-making to force a sudden, enduring quantum change in how they relate to their own suffering.
If we connect this to the bigger picture of global healthcare, the hurdles to making this a standard, accessible treatment are immense. We're dealing with a Schedule I legal status in many jurisdictions, which severely strangles research funding and access.
Red tape is massive.
Huge. Furthermore, because psilocybin is a naturally occurring compound, traditional intellectual property models just don't easily apply. That makes pharmaceutical funding really difficult to secure. These trials rely heavily on philanthropy.
And the logistics alone.
Right. The logistical healthcare infrastructure required is monumental. You can't just dispense a bottle of pills at a pharmacy window. You need specially designed, acoustically treated rooms, 2 highly trained clinical guides dedicated to a single patient for an entire day, and sometimes provisions for overnight observation.
It's a heavy lift for any hospital.
But despite these massive logistical hurdles, what we are witnessing in the data is the potential for a seismic shift in psychiatry. We're looking at a move away from the chronic, lifelong, passive administration of symptom-managing medication and moving toward short-term, active, intensive, experience-based healing. The source material we unpack today places so much emphasis on how this compound works by enhancing our meaning response and vastly expanding our capacity to feel awe. And that detail is hard to shake. It makes you wonder if a fundamental daily lack of awe and deep personal meaning is sitting at the root of so much of our modern epidemic of anxiety and depression. What does that say about the environments we had built for ourselves? We started today talking about how comforting a clean, precise X-ray is. We love a clean line on a chart. But perhaps when it comes to healing the human mind, we don't need a clean line. Maybe we need to surrender to the murky, unquantifiable, overwhelming vastness of the universe. And while medical science continues the long, hard work of bringing this specific therapy safely into the clinic, it leaves us with a question for our daily lives. What are the small, deliberate ways you can start injecting a little more awe into your own default mode network today?